apps. Sorry for the extra step, but I am trying to help the people that can't be here. Not like anything we've been covering is going to be on the exam, but if I get through the rest of the central nervous system today, I might very well be doing review material for the exam. I'm trying to do that. All right, so first of all, let me make this bigger so you can see it. I went through and took all the tests, chapter 2, part 1, metabolism, the practice test, chapter 2, part 2, cell transport, chapter 4, part 1. Everything is fine, except if you look here. Get rid of that. Right here, practice exam, chapter 2, part 2, updated today. Fixed answer for number 9. I didn't realize that. So if you go to that, I've updated the practice test and everything else is fine. So I updated this September 28th. And so question 9. And so I'm real careful because I want to make sure you have all the right information that you're studying for. And since I put so much emphasis on using these practice tests because I'm pulling questions from them, I put here the answer was C. I think before I had D, but it's E. All right. And so basically, if it was number 9, and it is, yeah, that's an important one. Sodium potassium pump. I don't know why I had this, but it's this. E3, sodium out of the cell for 2 potassium in. All right. I'm trying to send an email reminder out that I made this change to that test for the people that aren't here this morning. All right. So I think I've covered all my bases. And in the event that the weather is such that we have to cancel, the exam will be on Monday. I'll send an email out about that as well. Yeah. Only with respect, that's a very good question. So I'm not going to be asking in this exam epinephrine fight signaling and its alpha, beta 1, beta 2 adrenergic receptors. All right. I'm not asking a question about that. I think I went over it in lab for the lab review. That's going to roll over into a future quiz or something like that. So this is for that chapter 4, part 1. It ends at acetylcholine signaling disorders. What else? GABA. Since I talked about GABA in cholinergic syndrome, one of the treatments, Valium stops the seizures by promoting GABA, which relaxes your muscles. All right. So, I mean, you might want to know that just as far as like treatments for cholinergic syndrome. But other than that, no. Okay. So any other questions? Right. This time I'll remember to sign. We got the last 2 times because of one thing or another. Okay. So we left off. Let me get this out of the way. That's annoying. Okay. Get out of the way. There we go. Okay, the last thing we covered was, of course, the subdural hematoma, the real thing that you as nurses are going to see it. And that was interesting. Now we'll talk about ways of evaluating the brain that are visualizing techniques. All right. And so all of these you become familiar with. Of course, you don't have to know all this information. You could keep it for future reference, like relative costs and everything like that, and what's best for viewing. But if I ever asked this on a future exam, I would describe the imaging technique and you'd pick it up from a multiple choice answer. But x-rays, all right, radiographs are going to be the most common things you're going to see because they're not that expensive. Not that, they're still expensive, but not as expensive as the others. It's great for if you suspect someone has a broken bone, all right? And that includes a fracture in the skull. So a single x-ray beam is sent through a body part and produces an image where high density tissues like bone show up as white. Low density tissues like air spaces show up as black, and tissue is some middle ground of grays, all right? But it's not best for viewing soft tissue. That just is kind of muddled, all right? So there's a time and a place for each visualizing technique. I need some more tea. My voice sounds just like a frog. It's this weather coming in, dropping barometric pressure. It's causing my sinuses to go haywire. CT scan. Anyone here had a CT scan? They put you in this device just like this and makes these like click, 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 right? All right, it's kind of scary, claustrophobic. Multiple x-ray beams sent through the body and it advances through a tissue. So if it was going through my arm, it could go like this, and you could progress and get all these images going through a tissue or an organ or something like that. Really cool. YouTube it sometime. It's pretty amazing. More expensive, but oh, and a computer is used to put all those pictures together. It's computerized or computed tomography. That's the CT. It's good for soft tissue. All right. And it's middle ground, expensive, more expensive than a radiograph, less expensive than an MRI. But really, if you suspect someone has a hematoma, head trauma, CT scan immediately. All right. The CT scan in the video we watched yesterday, the woman who fell and had the big subdural hematoma. So here is a hematoma intracerebral. Okay. So here's a normal CT scan, and then obviously that's abnormal. So that's another technique. MRI, price goes up. It's the best quality image. It's a strong magnetic field, thus magnetic resonance imaging. And I think this is way undershooting it. But when I looked it up a couple of years ago, that's what it cost. Is there any downside that you know of putting someone through a strong magnetic field? If they have any metal implants, titanium rods, clips, pins, anything like that, pacemaker equipment, all right, other things like that, you can't put them in it because that strong magnetic field can shift those metal pieces in their body, and it could shift them in a way that could be very dangerous. PET scan is really cool. I don't know if you'll get to see that, but this is the one where someone's completely like wide awake, of course. Like the others, they're wide awake too, but they inject someone with a radioactive glucose tracer, and parts of your body that are really metabolizing using glucose are very active, like your brain. It'll show up bright colors like the yellows, the oranges, the reddish. That means really active, metabolically active. Areas that are not active at that particular time, cooler colors like blues and darks and violets and stuff like that. Well, what's neat is here's a normal PET scan of someone. These outer regions are your cortexes, like frontal cortex, parietal cortex, occipital cortex, all of those. Here's someone who has some mild cognitive impairment. And so a little less bright frontal lobe, a lot of less activity. And then in Alzheimer's, look at all the darkness. Alzheimer's, they're losing acetylcholine producing neurons in the brain. Still don't know what's causing it. Acetylcholine is always supposed to be stimulating your brain. Once you lose those neurons, they're not coming back. And those parts of the brain, anything that goes without stimulation in your body for a while, it's going to atrophy. And so this is atrophy. And we don't have the means, knowledge, techniques, medications to stop that or reverse it yet. Maybe one day. All right. So there's a time and place for every scan. And then the last scan, this is cool. We actually have one in the physiology lab, but we only have one. And it's not conducive or easily conducive to working with students because you have to put electrodes all over the head, and there has to be an electrode gel to make good contact. And so your hair is going to come out all wonky after that, right? So that's, but anyway, you can look at electrical brain activity. And do not memorize these, okay? But when someone's thinking, they'll have a certain wave. When they're alert, conscious, and aware, they'll have a certain wave. When they're kind of drowsy, meditative, they'll have these. And when you're in deep sleep, like rapid eye movement or something like that, you'll have these slow waves right there. If someone is wide awake and alert and they have these waves, that doesn't match up right, okay? If someone is deep sleep and they had a very active brain, that doesn't match up either as well, okay? All right, so moving on from those. Coop, contra coop brain injury. Okay. It's basically a concussion, all right, but that's the fancy name for it. And it's a very common injury. You hit your head, you fall down. It could be a car accident, when anything that causes your brain to basically bounce within your cranial cavity. All right. So someone's in a low speed car accident. They're driving maybe 30 miles an hour, and everything in your body is moving with inertia. And all of a sudden you stop. See, your brain is in your cranial case, and it's got connective tissue in the meninges layers that cover it, but it's going at 30 miles an hour. And when you stop, it goes toom, 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 inside that cranial case. All right. Every time it hits against that bone, it could have problems. You could have a bleed. You could have just general damage and inflammation to the brain. and that there could be swelling and there could be problems. All right. So these things are not to be taken lightly. If someone comes in and they looks like they've had a concussion, number one, talk to them, your name, do you know where you are, evaluate their mental state. If they're at all confused, that's not a good sign, CT scan. If they have lost consciousness at any point from when the paramedics picked them up, brought them to the hospital, till they came into the emergency room, if they've lost and correct me if I'm wrong with this, because we have the EMT, is it a kind of a more of a danger signal if they've lost consciousness or they come in and out of it? That's usually not a good sign. Another not a good sign is they're combative. They're not drunk or anything, but they could just be jerks. All right. But if they're otherwise, their family is with them and say they don't normally act like this and they're combative, that's also a classic sign of head trauma. All right. But here's the damage. That's what happened to that actor's wife, Liam Neeson. His wife had this. She hit a tree when she was skiing, obviously had this damage. It caused the hematoma that eventually killed her the next day. And so that's the problem with it. So this is what's happening. See, all right. I don't know if it'll see, boom, 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 hitting bone. All right, that's the damage. And so that's the problem. People like this who you suspect they have damage, inflammation, a bleed, they go to a scanner to find out if they do. But they're going to pound them with anti-inflammatories like prednisone, prednisolone, whatever zones they have, and that's supposed to bring down the inflammation. They have devices to measure intracranial pressure to see if the brain is swelling. All right, all these things. I'm talking a lot. There's only this on the slide, but this is a real thing you're going to see. You're going to see it on the reg. So be aware of it. All right. Okay. Let's see how much of this I have. I might skip some stuff here because I don't think I'm asking any questions on the exam. And I really would like to get to that review of acetylcholine signaling, which is the next chapter, chapter 4, part 3. But you should know from anatomy, this should be reviewed, that our spinal cord has regions that are named after the vertebrae that they pass through. So you actually have C1 through C8 spinal cord regions that run through the vertebral foramen of the cervical vertebral bones. I don't know why we only have 7 vertebral bones, but we have a C1 through C8. It's just the way it is. But notice this, again, especially if you end up working for a neurosurgeon. I've kind of put it here to color code it. C4 injury, C6 injury. All right. Notice that in the cervical region, a lot of the nerves that control your upper, of course, your head and your neck, but your arms are in that area. They come off the spinal cord at that area. So if you have a spinal cord injury in here, like C4, all right, look at that, tetraplegia. They've lost control. That's paralysis, plegia, of basically everything below the collarbone. C6, almost to them, but not quite. You've got a little bit of control in your shoulders and neck and everything, but everything else. And that is if you've damaged the motor part of your spinal cord. I'm going to get into this. Let me ask you this. They might not have covered it in anatomy. Your spinal cord has a anterior and a posterior, or anterior, ventral and a dorsal region. Ventral is towards the belly side, dorsal is towards the back. Which side of the spinal cord is where all motor commands are going in? Well, they're coming down. Is it going to be the ventral side or the dorsal side? Any ideas? Never covered it? The ventral. Motor commands come through the ventral part of the spinal cord. Dorsal part of the spinal cord is for receiving sensory information. So if you suspect someone comes in, they've gone to a scanner and you can see there's inflammation or something in a certain part of the spinal cord, and if it's in the ventral side, that would explain why when they're awake and aware, they don't have movement in that part of their body anymore. All right. But if it's in the dorsal part of their spinal cord where the damage occurred, you could pick them with a pen or whatever and say, do you feel that? Do you feel that? No, I don't feel anything. All right. So there's a division in the spinal cord. That's what I'm getting at. Then the thoracic part of the spinal cord matches the number of vertebrae. The lumbar part of the spinal cord matches the lumbar vertebrae because there's 5. And the sacral, even though you studied it as one solid bone in anatomy, it's actually made up of 5 fused parts. All right. And then some textbooks will include a coccygeal version of the spinal cord, but basically remember it's flaring out into the horse's tail, cauda equina, basically right around here. So again, am I going to ask you these in the, maybe on the upcoming second exam? Maybe. I haven't written it yet, so I just wanted to go over it. Okay, so this is important for you to know because none of you knew really the division of the spinal cord. So white matter. Remember how I said, oh, this could be review? No, it's not on the test. No, definitely. White matter is white because it's neurons that are myelinated. And myelinated neurons come across as white, especially on a scan. Myelinated neurons are getting information from point A to point B. They're your body's high speed, and it's not wireless, it's completely wired neurons communicating, but it's your communication network. Think of it like all the power lines you see, all right? That's what they're doing, communication getting from point A to point B. But it comes up as light colored. In your brain, I have figures here. There we go. In your brain, here's a cross section. These parts that are light are all the white matter. Any place you have a cortex or deep cerebral nuclei, they don't have myelin. So this is the parietal lobe with its cortex. Here we have the insular lobe, temporal lobe, not visible are the other ones. And here are our, that's brain ventricles. But here we have the deep, those are the thalamus right there. And our colostrum, our putamen, our globus pallidus, and our amygdala are right in there. Those we talked about before, and the caudate nucleus and all those things, those are going to come up as gray because they're cortexes. There's neurons that are receiving information and sending out motor commands. That's a cortex, all right? Okay, in your spinal cord, the arrangement is different. So here's our spinal cord. In the brain, the cortexes and the gray matter is usually on the outside with some spattering on the inside. And the white matter central. On the spinal cord, the white matter is all on the exterior and the cortexes are inside. So what's happening? Gray matter is pigmented neurons. They receive sensory information like your motor cortex in your frontal lobe, all right? Precentral gyrus. It's receiving sensory information that's going to be important for coordinating movement. And then a motor command comes from that frontal motor cortex, all right? Like, we don't see it on this. And then it's going to come down the spinal cord, right? That command, that motor command. And then it's going to come out the spinal cord on the ventral side. Everything from the cerebral spinal is like the line separate, ventral and motor commands come out this way. Sensory information goes in this way. That is the division of the spinal cord. So the point of covering this is people with spinal cord injuries. Well, what part of the spinal cord? First of all, what region? Cervical, thoracic, lumbar, sacral, so on. And then was it ventral or dorsal? That's very important to determine what deficit they might have, possibly short-term or long-term, okay? So, and when we get to the muscle chapter, I'm really going to spend some time talking about that ventral and dorsal root, all right? Okay, so information, let me see what my pen is doing this morning. Wakey, wakey, let's turn it around. So motor commands go this way. They leave out through the ventral side. Sensory stuff is going this way. That's the division, all right? And here's the line of separation. That's important. Maybe not for your regular nurse duties, but if you're working for someone who does neurosurgery, neural physical therapy, things like that, that's all going to be very important. Okay. So obviously don't memorize this. It's just meant to show you the same thing I've been talking about. If we have a motor command coming from the brain, like the motor cortex, like the cerebellum, like the caudate nucleus, like the putamen, globus pallidus, the red nucleus, all these things that have a say in motor control. That motor command, after going through all those brain regions, comes down the spinal cord, comes out here, and look where it's going. To effectors, skeletal muscles or glands, or just, muscles or glands. It could be going to the heart. It could be going to the smooth muscle. It could be going to skeletal muscle, but it comes out here. If it's sensory information, okay, touch, pressure, pain, all those things, that information is picked up by sensory nerves like thermoreceptors, all right? Picks up that information, enters the spinal cord in the back, and then goes up probably to the parietal lobe sensory cortex, right? All that stuff is important. I mean, have you seen images like this from anatomy? Yeah. All right. So at least it's not completely foreign. Okay. Now, do not memorize this, okay? Unless you end up working again for a neurosurgeon. But I want to introduce you to the concept of sensory body maps. I gave you one in the brain. where you go deep down the longitudinal fissure. As you go up there, it's going to be, you know, tongue. No, that's on the outside. You're going to have groin, and you come up, and it's going to be your legs, and you should curve over your torso. As you get further over, it's your arms and legs. You get off to the side of that brain, it's mouth, swallowing, and all that stuff. That was that map. This is whole body map based on spinal cord. All right. So I tried to color code it. Light brown is C1 through C8, sensory perception. All right. Skin's sensory body map. So if they have a spinal cord injury in the dorsal area of the spinal cord in this region, that is for sensory perception of the back of your head here, neck and shoulders, and the dorsal and lateral arms here, sensory perception. So then you could explain to the patient why they can't feel you touching with the pin in those regions. The thoracic is more yellow orangey. So basically that's thorax front and back, sensory perception. If it's lumbar, it's lower back because that's the lumbar region. All right. And then in the front, it's basically from your hips all the way down the front of your legs. All right. Sensory perception. And then lastly, sacral spinal cord region for sensory perception of the groin, and then the anus, and then the back part of the legs, like the hamstrings and so on. All right. So you wouldn't have to memorize the map, but I could say this dermatome provides sensory information for this part of the body, and then I'd have A, B, C, D. All right. Not this test, some future exam way down the line. Now, speaking of the dermatome, sensory perception, and that's pain too. Shingles. How many people have had the chickenpox virus in their lifetime? Chickenpox, anyone? Oh, wow. Okay. Hopefully you don't get it as adults. I had it as a kid. And it's basically, it's viral in nature. You learned it in microbiology, varicella zoster. But anyway, when you're young, it causes itchy little rashes and things like that. And you want to scratch. And so if you contracted it, if you had it already, the thing is, some people's immune system is really good and it clears the body of the virus and it's gone. But more often than not, viruses are sneaky. We know this from HIV, shingles, human papillomavirus, AIDS, HIV, and some other things like chickenpox virus. It'll hide in your body, sometimes for decades. And then later on, for whatever reason, it will re-emerge and cause problems. Shingles is one of these. So what happens is the virus lies dormant in the dermatome, dorsal part of the spinal cord, for many years, who knows how long, and it might reactivate. It could be a time of severe stress, or you went through a really serious illness, maybe you got COVID or who knows what, and your body was stressed. And then, the virus says, oh, your immune system's weakened, I'm back. And it causes these very painful rashes and blisters, usually on one side of the body. My brother had it, he said, really painful. And so since he got it, and he's the one who gave me chickenpox when we were kids. But anyway, I went and got the vaccine because I wouldn't want that to happen. So we do have a vaccine for it now. So if a patient comes in and then through the patient history you're gathering, you find out that they had chickenpox, or even maybe the kids had chickenpox, because just because you acquire the chickenpox virus doesn't mean you're going to show physical symptoms. All right. There is now the shingles vaccine. I got it. No worse than a COVID vaccine, and it's supposed to be 2 to 6 months apart. So this is for people who have known a family history, they've had it or been exposed to it. It can just reduce the chance of that painful outbreak. All right. I know a vet who was stressed and she had a shingles outbreak on her face. She said, oh, that was just lovely, that they thought maybe I had herpes or something. I don't know what's right there in her face. So it can be painful and also very visible. Okay. Do not memorize anything. I'm not even going to ask you the tracts. I just want you to be aware, since I asked, do you know the divisions of the spinal cord? Do you know about information going up versus coming down? And you didn't. Spinal cord tracts communicate with the brain. Okay. The ascending tract, ascending means going up. So this is going to be, this is a temperature receptor, pain receptor, any sensory receptor. Information is going up the spinal cord. It gets sorted at the thalamus. And this tells me right here, it's going to the parietal lobe's sensory cortex, known as the postcentral gyrus, because that's the place it needs to interpret that information. All right. Now, if based on, say, a pain receptor, this cortex, sensory cortex said, ow, that hurt. A motor command is going to come from motor cortexes and other places in the brain, and then that's going to go down. And that's called a descending tract. You don't need to know all of that. And basically, it's important for complex voluntary movement. So a motor command is that hurt, remove your arm. That comes down the spinal cord, right, from a motor cortex and goes to a muscle cell or a gland to have that effect. Now, the only reason I go over this is to go over the Babinski reflex, which this is in the way. This is something that nurses do on the reg. Okay. Get that up and out of the way for now. So Babinski reflex. Anyone know what it is before I've covered it? Baby's born, you do all kinds of tests to make sure everything's functioning, they're okay. How are their lungs? How, are they yellow? Are their reflexes working? Because they come out, they're not always fully cooked, and you want to know what the problem might be. And that's the baby's born and they hand it to the nurse. All right. And so there's all these things you're going to do. Oh, not responding. So cortical spinal tracts are important for complex voluntary movement, speech. If there's damage to these tracts, you might have speech problems. We covered that, aphasias. Damage to these tracts can be medically tested by the presence of the Babinski reflex. So I think Babinski, I think baby, but it's not always used in just babies. In this test, the sole of the foot is stimulated in a particular way that causes normal adults to produce downward flexion or curling of the toes. So I got boots on, but dorsiflexion is when I do this movement, like this. My toes are going like this, all right? And I'm using my gastrocnemius muscle. So they go down like this, like that, all right? In infants, in normal reflex in babies is right here. They will splay or dorsiflex, their toes go up like that. That's normal for a baby. In adult, normal Babinski is curling of the toes. If it's reversed, if it's an adult and their toes do this, we've got damage to a cortical tract for one reason. And if the baby, instead of doing this, does that, that's abnormal. Okay. So I have the normal reflex of this in the baby. Let's see if this is working. Might take a second. There. And this is something that nurses do. It's real easy. So here's the baby's foot, and they're going to stroke it there. And notice what the toes are doing. They're flaring up. That's completely normal, right? Okay. But in an adult, back out of that, okay? And we have both, I think. And the guy's just pretending, just to show what it looks like. Oh, we have an ad. And skip. Okay, so here we have an adult, and they're stroking. That's normal. Curl the toes. Plantar flexion towards the sole of the foot. Okay. Now, abnormal, they're flaring out like a baby's toes would, but that's not normal in an adult. All right. So that tells you that a cortical tract had some sort of damage or problem. All right. So thus endeth central nervous system. Okay. Which is great. And I'll post these notes later today. What we do get to do is to go on to this one right here. And this is why I'm glad is that I get to do review with you for material that's going to be on this exam, acetylcholine signaling. There we go. Okay. Now for my Tuesday lab, I do apologize. My website is obviously back up and working. Monday's lab, I was able to pull all my flow diagrams out and go over them with you and all that stuff. My Tuesday lab, not so much because my website was acting weird, but we'll be able to do it today. So communication between the brain, spinal cord, and your body, sensory versus motor. We just kind of talked about that. But sympathetic and parasympathetic control, very important in nursing pharmacology. And so we've covered a lot of how nerves control skeletal muscles. So, but if you're wondering what this is a plastinated nervous system of someone. They put their body, I don't know how they've done it. I don't know the process, but it's showing you brain, spinal cord, and then everything off is the peripheral nervous system, which is kind of a really cool way of looking at the body. But this should look familiar. Okay. So in the central nervous system, you are going to want to know this stuff. Okay. There is let me get a different pen color. There is the somatic, sensory division, which is all about it involves your muscles, your joints, connective tissue. Okay. It's receiving sensory information from these things. Touch, pressure, pain, vibration, all that thing. We have sensory receptors in our joints that provide feedback to the brain for movement and balance. Those joints are providing feedback. And then, of course, in our connective tissue, we have a lot of sensory perception. In the other division is the visceral sensory division. Okay, what are viscera? It's an organ, okay? I'll say sensory perception from organs. I'll just put organs for space. How does your brain know you're full? When your stomach is full, it stretches. There's stretch receptors. How does the medulla know blood pressure has changed? All right. Stretch receptors in the aortic arch and carotid arteries known as baroreceptors. How do you know you have to pee? Your bladder gets full and it stretches. There's stretch receptors. So those organs, and then other organs have all kinds of receptors that provide feedback of something that needs to happen. And then lastly, special senses. Okay, that's sight, sound, taste, things like that. All right. So hearing, seeing, tasting, other special senses that we have. That's all that information is going up mostly to the parietal lobe. Okay. So that's pretty simple. And I think we cut the sensory lab this semester, so you won't be testing these things. Oh, well, we are testing taste next week in lab. All right. So we will be doing that. Kind of a fun lab. Okay. So here comes the review. Motor. So this is all ascending. That means sensory. And this is descending, which is all motor. Okay. Motor commands coming down from the brain, going out the spinal cord. We now know the ventral side, and then going to muscle cells or glands. Okay. Oop, I didn't mean to do that. Okay. Voluntary motor responses. Skeletal muscles, right? So this is review from chapter 4, part 1. It's stimulated by a somatic motor neuron. This is again at the beginning of chapter 4, part 1, where I divided motor neurons, sensory neurons, and interneurons. Okay, now here is the pop quiz for the test that's coming up on Friday, or hurricane on Monday. All right. What is the neurotransmitter? All voluntary movement involves this neurotransmitter. Answer me. Acetylcholine. Perfect. Okay. So you know its receptor is going to have the name choline in it, right? It's going to be a cholinergic. You don't believe me? Choline is literally part of the receptor name. But now you have two choices, right? Nicotinic, muscarinic. Which one is it? Nicotinic. All right. Oop, no, I don't want that. And you probably remember now, because if this was a cigarette that had nicotine, I'd have to use voluntary muscle movement to pick it up and put it to my mouth, right? Maybe you'll never forget that now. Hopefully, then my job is done. Okay, involuntary, things you have no control over. What do you not have control over in your body? Smooth muscle. Okay, We've done this before. What's another muscle? Cardiac. So those are muscle cells. What's something else you don't have control over? Glands. Involuntary motor responses go to these. It's going to be an autonomic motor neuron. Okay. And then obviously down here, it subdivides if you've looked at this pathway for the acetylcholine signaling. All right, so we're done with this. This ends here. All right, we now know, and you know from the quiz and lab, that this motor neuron releases acetylcholine, binds to a nicotinic cholinergic receptor, and opens up what ion channel? Sodium. Yeah. Okay, now we're going to take the two diverging paths. Parasympathetic responses, sympathetic responses. And so there it goes to here. All right. And so I put in cool blue parasympathetic motor responses. This is rest and digest. On the opposite extreme, red, danger, danger, danger. Your epinephrine responses, your sympathetic responses, your fight flight responses. All right. Okay. This is where we're doing a review, but I will get into this today, but this is not on the test. This is on the test. All right. So we got the time. I'm going to use it. Parasympathetic. Okay. This first box are things happening in the thoracic region. Same thing over here. Ditto. Here is in the pelvic region. That's why I've broken them up. Same thing here. Okay. It's cool blue. Let's go here. Answer this first. All parasympathetic motor responses work by this neurotransmitter. We did this review. I even gave you examples, and the practice test has this as a multiple choice. Oh no, a matching series of questions. Acetylcholine. Okay, you know it's going to be a choline. There's cholinergic receptor. But now what's the word that comes in front of it? Muscarinic, because you must. You have no choice. It's autonomic. Your body's doing it for you. And it's influenced by this neurotransmitter. Okay, let me add on the nerves. The nerves are not on this test. This is, all right, because I told you this, and I've got a specific flow diagram where I blocked it out. Okay, well, let's stop, because I'm more concerned about, let's say, what is happening to your heart rate in rest and digest? It goes down because you're calm. Your life's not in danger. If your heart rate goes down, your blood pressure goes down. Now, what about your bronchioles? It's rest and digest. They're going to be wide open to get all available air. They're going to bronchoconstrict. They're not going to close down. They're just going to constrict a little bit. Now, what about all things GI? Increased activity or decreased? Increased. So GI peristalsis goes up because it's rest and digest. It's a good time to digest. GI secretions, salivary, enzyme secretions, all this stuff goes up. Now, blood supply to the gut. If you increase blood supply, you'll vasodilate. If you decrease blood supply, you'll vasoconstrict. What do you think would be good when you're digesting? To constrict those blood vessels and narrow the blood flow, or increase blood flow because it's active? Increase it. And it also vasodilates because when you're digesting, you're going to be absorbing nutrients into that bloodstream. And so that's going to be, but mostly it's to provide the oxygen and glucose for the GI muscles to work. Okay. Now, down here, rest and digest. Is it a good time to stop and go potty? Yeah. Increase urination, increase defecation when you're under full rest and digest parasympathetic control. Like one of the first things in the morning is you're calm, you're sleeping, unless you're stressed and studying for a test. That's the urge to urinate and defecate. Okay, now here's the nerves that do it. Back up to the top. The sacral nerves control those thoracic responses. All right. Sacral nerve is a huge, it's a cranial nerve. It goes all the way down into your abdominal cavity. It's a huge nerve. All right. And there's pairs left and right. And then for this, not the lumbar, not the sacral. Oh, I'm sorry. Cross that off again. That was a brain fart on my part. Sacral goes down here. I meant to say something else. Sacral nerve's not very big. This goes here. Vagus. Yeah. We're all entitled to a brain fart every now and then, right? That was mine. It's the vagus nerve that's a huge cranial nerve that goes all the way down. Sacral is not as long, and it is in the sacral region, thus it's controlling pelvic functions. Now, how the hell are you going to tie the vagus nerve to all those functions and the sacral nerve to all those functions that are rest and digest? So, and I think when you go to Vegas, the location, all right, on vacation, all right, go to Vegas on vacation. Notice all the V's. When you're on vacation, you're calm, hopefully, right? So think vagus nerve, you're on vacation, you're calm. It's controlling the rest and digest functions in that area. And when I think of sacral nerves, I think of soothing sacral, all right? And since the sacral bone is part of your pelvis, it's controlling pelvic structures. So that's the increase in urination, defecation, because you're soothed, because you're under rest and digest. But you do not have to know those nerves for this test. You do have to know, especially this stuff. I was heavy on this stuff, all right? So if you got this and this, you're good, okay? All right. Now, the flip side of rest and digest is going to be sympathetic. Okay, so fight, flight. Basically, most of the stuff reverses. So let's start here. All sympathetic motor responses work by this neurotransmitter. What's the neurotransmitter? It's known as adrenaline. Epinephrine. Okay, I'll even write it down here. Epinephrine equals, oh, I'm running towards the end of my screen, adrenaline. And guess what? The receptor's named after adrenaline. All right. So they're all going to end adrenergic, adrenergic, adrenergic. Okay. But I gave you three precursor to the adrenergic, 3 ones. Okay. There's more than that, but I taught you through. Okay. Let's just stop. Don't even look at this right now. Okay. Okay. How about I put in front of this beta 1 adrenergic? Where's that receptor found in the body? It's going to control heart rate. Okay. Beta 1 adrenergic receptor. Epinephrine binds to it. Now, tell me, in a fight flight response, when epinephrine binds to that beta 1 receptor on the heart rate is doing what? Goes way up through the roof. That makes your blood pressure go through the roof. Your heart is speeding the rate at which oxygen and glucose get to all the life-saving functions of your body. Increase blood flow to the brain, to the heart itself, and to your skeletal muscles so you can fight, flight, whatever you need to do. If I put a beta 2 adrenergic receptor there, where are you going to find those receptors for epinephrine in your body? Your lungs. Okay. B2 receptor. I'll just put receptor. Heart B1. I'll put it adrenergic. Okay. Okay. Now, what do your bronchioles do in fight flight? They're going to bronchodilate. They bronchodilate to get all possible air into your body so all of those important life-saving organs can save you. They need a lot of oxygen. Your brain, the heart itself, and your skeletal muscles are going to need all that oxygen to fuel the fight or flight. All right. How about all things oh, there we go. Got ahead of myself. Alpha, apple, digest. Okay. It's fight flight. Is it a good time to digest? Is that going to save your life? Hell no. All right. GI peristalsis, shut it down. GI secretions, shut it down. That's why some people feel dry mouth when they're scared. It's because salivary glands are a digestive function. How about blood supply to the gut? Think it's a good time to waste all that glucose and oxygen in that blood to the gut when its function's not going to save you. No. You're going to constrict. It doesn't shut off all the way or else the tissue would die, but it narrows. The body is not going to waste valuable blood supply on something that's not going to save you. Your body's going to be diverting blood to your brain. That can save you. To your heart itself, which is pumping like mad. And to your skeletal muscles, which will help in the fight flight. All right. So now if we look at skeletal muscle arteries, you're going to think you're going to have increased blood flow or decrease. Increased blood flow because they need all that oxygen glucose for the fight flight. So those arteries will vasodilate. And guess what? They work by a beta 2 adrenergic receptor because it's best to get away. Remember that now? Okay, beta 2, 2 lungs, bronchioles. Beta 2, best to get away. Blood flow to the skeletal muscles, which are going to allow you to fight or flight, run away. All right. Do all those make sense? Now, is a good time to stop and go potty when your life's in danger? Hell no. Decrease urination, defecation. And I didn't give receptors for that because it's just too much to throw at you at this time. There are, of course, receptors for that. Okay, the last thing we'll end on is the nerves. Up here for the thoracic functions is the thoracic nerves. Down in the lower pelvic region, going to be the lumbar nerves. Okay, how are you going to remember these nerves control sympathetic functions? Well, it says thoracic, so it's telling you it's things that are happening in the thoracic region. This is not thoracic, and this is abdominal, but this is thoracic and abdominal. Let me add that. And abdominal for this box and for this box. When I think of thoracic, I think of T, tense you up. If it's fight, flight, you're tense. Trust me, okay? So thoracic nerves are going to handle everything in the chest and abdomen, and it tenses you up. When I think of lumbar nerves, I think of the lumbar region, which is part of your pelvis. So it's going to control pelvic functions. It's going to shut them down. I think of let's get the hell out. Okay, fight, flight. It is silly, I know. You can come up with your own if you like, but this helps me remember the nerves and whether they're sympathetic or parasympathetic. But remember, all you guys are responsible for, my pen, is just this stuff. That's it for this test that's coming up. All right, that's for a future quiz or whatever. But I'm glad we got to do a review. Does it help kind of focus your brain, kind of going over it again? Okay, all right. So I may or may not see you on Friday. We'll see what happens, but whatever you do, be safe. All right, coastal people, be very safe. All right, good luck. And I will post these notes from this today, just because this part is good review for you. All right. Okay.